Very good morning to one and all. At the outset, I would like to thank the Scientific Committee of AIS for inviting me to speak here. I will be speaking on role of ASOCT in strabismus resurgery. Basically, role of imaging modalities in strabismus surgery is regarding understanding the etiology of strabismus, good surgical planning, and role becomes more important when previous surgical details are not available to operate the same eye or the other eye, to know the exact location of the muscle, the status of recessed or resected muscle or scar tissue. Various imaging modalities which are available are CT scan, MRI, USG, UBM, ASOCT. Why ASOCT is superior? With wavelength of 1310, it generates two-dimensional imaging of high resolution from a reflected beam of light. There is faster scanning, less scattering, high penetration into the turbid structure, that is opaque cornea, sclera, iris, angles, non-contact examination, suitable for children and postoperative assessment, no radiation hazard, no need of anesthesia. So this is the machine which is available at our center, and no financial interest. So this technology was first used in 1991 to image the posterior segment of eye using a wavelength of 830, and in 2001 the wavelength was altered to 1310 to allow better penetration through light retaining tissues such as sclera and limbus in order to improve the visualization of anterior segment. These are the technical aspects. So identification of muscle on ASOCT: in unoperated eye, the muscle begins as a curved, thin, hypoechoic structure at the fixed distance from the angle, and this corresponds to initial tendinous part of the muscle, which when traced posteriorly, the corresponding hypoechoic area occupies progressively larger space, which further corresponds to the muscle belly. So the hypoechoic structure at a fixed distance from angle corresponding to initial tendinous part of the muscle is seen in this figure. The longitudinal scans provide length-wide details and cross-sectional sections provide width-wide details, and hence combined scanning is more productive than isolated scans. Medial rectus muscle identification: in recessed medial rectus muscle, the anterior ocular coat contour can be unremarkable and posterior ocular coat contour can show variable thinning. In resected medial rectus muscle, the posterior ocular coat might appear thicker and irregular with variable conjunctival folds. So this is the resected MR muscles confirmed by increase in muscle thickness at the insertion site, and the recessed medial rectus muscle was found at 6.7 mm from the limbus. For identifying the lateral rectus muscle, it is easy as compared to the medial rectus muscle due to more working space and absence of plica semilunaris and caruncles, whose shadow hinders the visibility of the structures. A recessed lateral rectus muscle show all well-maintained anterior ocular coat and disturbed posterior ocular coat. In resected lateral rectus muscle, the bulky insertion site can be noted. This is the ASOCT image showing the insertion of lateral rectus from the limbus. So what are the errors which can be there in muscle identification? Post-operatively, the muscle imaging needs to be cautiously judged till 4 weeks, because the muscle space often erroneously appear as large hypointense layer which settles over a period of time with resolution of edema and conjunctival flattening. The large caliber conjunctival vessels can hamper and they can be judged as muscle areas. This can be avoided by carefully observing the muscle specific characteristics, and in presence of dense conjunctival folds or scalp, there might be some problems regarding the identification of the muscles. The identification of thin tendons and belly can be difficult sometimes, hence in these areas a correlational scan between longitudinal and horizontal scan can be considered for better clarity. Identification of muscle inserted more than 10 mm from the limbus cannot be identified in the ASOCT. So this was one 17-year-old male patient, and there was a case of resurgery, and these are the preoperative and post-operative photograph of the same patients. In ASOCT, the medial rectus was found at 7.8 mm, and with intra-op handheld caliper, it was found at 11 mm. On the other side, the ASOCT, the lateral rectus was found at 6.39 mm, but when we measured it with the caliper, it was found at 7 mm. This is second patient. This was case of residual exotropia with V pattern. These are the pre and post operative photograph. ASOCT was done and MR was found at 8.7 mm, and with caliper it was found at around 10 mm. The lateral rectus was found at 13.5 mm, and with caliper it was found to be at 14 mm. This is another case, residual exotropia with V pattern, pre and post op photographs. And when ASOCT was done with medial rectus, it was around 6.7 mm, and intra-op with handheld caliper it was at 7 mm, and lateral rectus was found at around 9.4 mm. This is another patient with residual esotropia. When ASOCT was done, medial rectus was at 9.45 mm, and intra-op with caliper it was found to be at around 10 mm, and lateral rectus was found around 8 mm with ASOCT and around 8 mm with the caliper. This is another patient with residual exotropia, and when ASOCT was done, MR was found at around 7.7 mm, and when we measure it with caliper, it was around at 8 mm. ASOCT lateral rectus was not well appreciated, and with caliper it was around at 13.5 mm. This is another case. In ASOCT, it was around 8.7 mm. With caliper, it was around 11 mm. And ASOCT lateral rectus was found at 10.8 mm, and with caliper also it was same. So this is another case of consecutive exotropia. These are the pre and post operative photographs. And when ASOCT was done, MR was found at around 7.9 mm, and with caliper it was around 8 mm, and lateral rectus was found at around 7.5 mm, and with caliper it was around at 8 mm. So the extraocular muscle insertion site is treated as a reference point in calculation of amount of strabismus surgery. Since prior strabismus surgery can alter the insertion point of muscles, a careful preoperative evaluation is mandatory, and ASOCT helps to design a surgical plan by localization of displaced extraocular muscle insertion. In a study done by Subhash et al., and the muscle insertion could be identified in 12 cases on ASOCT and 10 cases on UBM, and maximum insertion distance on ASOCT was 13.8, and on UBM it was 10.4.
Yeah.
And in another study done by Dr. Amar Purzari et al., they concluded that preoperative ASOCT can provide reliable muscle details with respect to its type of surgery and amount of surgery. The strength of study were practical role of non-contact imaging, highlighting features of recessed and resected muscles, and imaging and deeper penetrations. Limitation was small sample size, lack of universal landmarks, and lack of measurement of actual distance. So to conclude, ASOCT with its advanced scanning ability can be utilized to locate extraocular muscels locally. It is really available for preoperative assessment of EOM without additional expense, and can be performed even by adequately trained technicians well versed with the procedure. And this cross-sectional imaging tool can reliably be used as interrogative tool or a surgical guide while planning surgery in routine as well as in complex cases. Thank you.
Thank you, sir. I would now like to